Good afternoon, everyone. Welcome back to our COVID-19 workshop. I'm Dr. Ralph Zheng, your moderator for the coming two sessions. It's my privilege to introduce the first speaker, Professor Grace Loy. We have known Grace Loy for a long time and have been working for a long time as well. Professor Loy is the Assistant Professor and Head of Division of Infectious Diseases, Department of Medicine and Therapeutics of CUHK. Her research interests include comorbidities in HIV, tuberculosis, antibiotic stewardship, and antimicrobial resistance. She has also worked on new diagnostic tools to aid early diagnosis and treatment of pulmonary and extrapulmonary tuberculosis in hospitalized patients. So without further delay, please welcome Professor Loy.
Thank you very much, Ralph, for the invitation. It's really my pleasure to join the workshop today and to give this talk. Today, I would like to share my own experience and what I have learned from SARS and COVID, and very much from an infectious diseases physician perspective. I will try my best to address issues both at the individual level for healthcare providers and to a lesser extent, the level of the health system. No matter how much people disagree on various issues regarding COVID, I suspect few would disagree with this statement in an article in BMJ earlier this year, describing the varied national responses to COVID. COVID has exposed and exacerbated existing flaws in public health systems around the world. I believe the same statement does apply to the practice of clinical medicine. COVID gives all of us an opportunity to reflect on what we have done in the last 1.5 years, both the good things that we have done, these have set examples for future challenges, and the things that could have been done better, so we can learn from our flaws for a better future. In this talk, I will share my reflections on our preparedness, our responsibilities, and our resilience as healthcare providers during this pandemic. If we go back in time, imagine you were at the beginning of the year 2020. Do you think our health system and you yourself were prepared for the upcoming pandemic? Or perhaps the term pandemic entails too large a scope, which is reserved for policymakers. The real question for an individual healthcare provider was, in fact, were we prepared to face a new disease? The first lesson I learned from this pandemic is how can we be better prepared when we encounter new diseases or new challenges we have never been through before. If we treat the pandemic as a battlefield, it would be natural to believe that we would feel prepared if we know our enemy and we have access to the right weapons. Therefore, it would be sensible to say that we would feel totally unprepared at the beginning of the year 2020, as we neither knew about the novel virus, nor did we have effective treatment or vaccines. But was that true? If we allow ourselves to go further back in time, we would find ourselves not at all unfamiliar with infectious diseases outbreaks or even pandemics. In just less than 30 years, we have experienced avian influenzas, pandemic influenza, 2 coronaviruses, Zika, and Ebola, and so forth. When we faced these outbreaks, big and small, we did have plans and systems in place to prepare for or manage these outbreaks. And each one of them, indeed, has served as an outbreak drill for us. Just before the pandemic has started, a group from Johns Hopkins School of Public Health reviewed how health systems should be assessed for their preparedness for public health emergencies, including infectious diseases outbreaks. If we go through the list of the 16 elements they delineated, we will find that Hong Kong, in fact, didn't perform too badly. And that was obviously due to the aftermath of SARS. As an example, one of the key elements is a leadership and command structure in place prior to the event with clear channels of communication. We did have clear plans for emergency response level, including plans for manpower deployment, infection control measures, service adjustment, visiting and volunteer arrangements, etc., even before the current pandemic. We also have infection prevention and control measures and protocols in place. Though we did have some concerns with the supply of PPE at the beginning of the pandemic, I would say that we had far better stockpile in Hong Kong than most other countries, mainly due to a much higher baseline consumption of surgical masks and alcohol hand rub. Very early on, our central pharmacy office has helped to ensure a stable supply of the potential drugs that might be useful for COVID. We have also learned from our experience from SARS 17 years ago. We tried hard to be flexible in our manpower and duty allocation in both the dirty and clean teams. Over the last 1.5 years, our colleagues adapted to repeated changes to our core system during the various waves of the pandemic. The first lesson I have learned is that we should make better use of what we do have. Highlighting our capabilities tactfully to our colleagues and public would bring assurance and a sense of security in the midst of a crisis. On the other hand, we do not need economic scholars to tell us that we all face the problem of scarcity of resources, which becomes even more pronounced during crisis situations. The Global Health Security Index, or GHSI, is a measure of countries' preparedness for pandemics and epidemics. The higher the score, the more prepared the country is expected to be. However, when we look at the scores published in 2019, just before the pandemic had started, it in fact had a positive correlation with the national cumulative death rates from COVID. One of the major reasons was that the lower income countries, which were assessed to have a lower GHSI score, they actually allocated their scarce resources more appropriately and tailored to context during the pandemic. Therefore, scarcity need not be a deterrent for healthcare provision, but it can be an impetus for efficiency and innovation. The second lesson, therefore, is to acknowledge what we don't have and try to find the solutions. One of the elements for preparedness for public health emergencies is to identify and dismantle barriers to healthcare access. During an infectious diseases outbreak, timely identification of infectious cases and isolation to avoid further spread is of utmost importance in containment strategy. Our major barriers to achieving this was our limitations in both testing capacities and availability of isolation facilities. In the face of resource scarcity, we do have to prioritize our needs. Testing and isolation have to be reserved for the highest risk groups when resources were scarce. For example, during the initial period of the first wave in Hong Kong, when mobilization of resources required more time, and with all cases being imported from China, we had to place travelers from China in the highest risk group while limiting testing for other populations. However, as the situation evolved, we should strive to solve the problem of scarcity by looking for alternative strategies to achieve the same goals. And as a last resort, we have to accept altered standards of care during crisis situation. Risk stratification was one of the keys for efficient use of scarce resources. Using patients' electronic records, we have identified the variables associated with poor outcomes in our local patients. And a predictive scores with high accuracy has been developed. We have been using this scoring system as one of the tools to identify patients suitable to be transferred to step-down wards or admitted to community treatment facilities during different stages of the pandemic. At the beginning of the second wave in Hong Kong, it was obvious that the existing limited isolation facilities in public hospitals were not able to serve the purpose of testing. These tents set up outside many AEDs in Hong Kong relieved our burden and greatly facilitated efficient testing and triage. The isolation facilities in our expo center is another example of seeking alternative strategies that might not be acceptable in non-crisis situations. If you remember my earlier analogy of knowing the enemy in the battlefield, we were definitely at a loss at the beginning of this pandemic. With so little data on hand, in our clinical decision-making, could we have the ability to practice evidence-based medicine? Let's look at hydroxychloroquine as an example. If hydroxychloroquine does play a role in this pandemic, this would be the lesson it has taught us on the practice of evidence-based medicine. We remember Mr. Trump's advocacy on using hydroxychloroquine in treatment and prevention of COVID. His claims were in fact not entirely without evidence. There was a French study released online in March last year showing more rapid decline in viral loads in patients receiving hydroxychloroquine and azithromycin. However, the sample size of this study was very small. It was open-label, non-randomized observational data, plus the patients admitted to ICU and those who had died were actually excluded from the hydroxychloroquine groups from this analysis. The experience with hydroxychloroquine was so painful in the US that it was again mentioned in Dr. Paul Sachs's blog earlier this year. He listed all the harms resulting from enthusiasm for something without any good evidence. But he also highlighted something very true for all clinicians. When facing a potentially deadly novel disease, we all wanted something that's safe and readily available to work. Indeed, this state of mind easily tempts any passionate clinician to just give my patients something that might work. So, what should we do when facing a new disease? Sensible medicine is an approach to treatment which balances the strength of evidence and the pace of knowledge translation. That is, the adoption of evidence into clinical practice. On one end of the spectrum, a hawkish interventionist has little doubt about the effectiveness and safety of new treatment and rapidly adopt it into clinical practice. At the other end, the medical nihilist is highly skeptical of any new evidence and hopes to intervene less. Both ends of the spectrum obviously carry flaws. In sensible medicine, we should not imagine that a magic bullet is readily available. We should be aware that non-evidence-based treatment does cause collateral damage no matter how benign the treatment seems to be. And we should rely on high-quality evidence. If we did take the effort to focus on the evidence that we do have, the situation wasn't that dismal. We have witnessed research for this novel virus being conducted at an unprecedented pace. On 23rd of January last year, we had the first 2 confirmed cases in Hong Kong. On the next day, there were already 2 articles published online in New England and The Lancet, reporting the characteristics of the virus, phylogenetic analysis, as well as preliminary epidemiological and clinical information from the first batch of patients from Wuhan. Over the course of just over a year, many trials have been performed with results released. The timeline here shows the treatment that has been proven to show some form of benefit, ranging from prevention to progression to severe disease and reduction in mortality. As alluded to earlier, clinicians do face a temptation to give something to our patients, be it only being supported by anecdotal evidence. At times like this pandemic, clinical trials to assess the efficacy and safety of new treatment is even of paramount importance. The recovery trial is an exemplar of what trials can do during a pandemic. It has just taken 9 days from conception to launch of this study, which is a concerted effort across many sites in the UK to compare different treatments with the current standard of care. In Hong Kong, we have formulated interim treatment guidelines early last year, with the first version mainly based on expert opinion and data extrapolated from previous coronavirus studies. Subsequently, various sites in Hong Kong did participate in clinical trials evaluating different antiviral therapies. Along the way, we have revised our treatment guidelines a couple of times when new data was released. The importance of evidence in implementation of vaccine rollout obviously applies to COVID vaccines, which we now have a plethora of data. And I'm sure Professor Cowling will enlighten us on this very soon. The second area, which I have some reflection in the past 1 year, is the people whom we are held accountable. As healthcare workers, we uphold ethical principles in our daily work. We emphasize beneficence and non-maleficence for a particular patient we serve. However, during this pandemic, serving parties other than the patient in front of us becomes responsibilities that are equally or sometimes more important. Healthcare workers are of instrumental value during a pandemic for obvious reasons. Addressing the needs of healthcare workers becomes a responsibility to sustain our contribution to society. Therefore, it is important we take care of our own basic necessities, things like accommodation, working clothes, adequate PPE, and a sustainable working duty arrangement. All these would help us to sustain our service to our patients. While a lot of resources and emphasis have been directed to patients with suspected and confirmed COVID, care of patients without COVID was compromised to different degrees. As we implement policies during the pandemic crisis, we also have the duty of care to patient populations who are vulnerable and being more affected by social distancing or other pandemic control measures. I am very delighted to see that one of the sessions of today's workshop is devoted to the discussion of teaching during the pandemic. Although it may be appropriate to place our students' and patients' safety as priority when implementing teaching policies during the pandemic, we do have the duty to take care of our future patients. Policies should take this into consideration of the quality of care we provide at this current time. Lastly, COVID has revealed the importance of the role of healthcare providers in the community, not just our contribution in direct patient care, but also our role in promoting community participation, which is one of the keys in success in pandemic control. The community expects us to provide them with correct and appropriate information regarding the novel disease and its treatment and prevention. Each one of us do have a duty to convey appropriate messages at appropriate times. Communication with our peers and patients and public is challenging even during peacetime, not to mention during crisis situations. The New Zealand Prime Minister has been very much praised both internationally and at home, not just for her aggressive measures in controlling the pandemic, but perhaps more importantly, the compassion she shows her fellow citizens in her communication with them. Her mantra, be strong, be kind, should be a reminder for us too when we face difficult moments in communication. Lastly, during last year, resilience is something that has come up in many circumstances. Psychologists define resilience as the process of adapting well in the face of adversity, trauma, tragedy, threats, or significant sources of stress. Even before the pandemic, burnout was common among physicians. We would not be too surprised that our local pre-pandemic prevalence of work-related burnout exceeded 50%. During the pandemic, we are bombarded with additional stresses. Our profession is to a great extent built on our knowledge. Lack of knowledge brings us insecurity. the fear and uncertainties associated with the pandemic definitely increased our personal stress levels. As healthcare providers, it is important that we take care of our physical, mental, and spiritual health, and not to be ashamed to face our own weaknesses and seek solutions when necessary. At the same time, the health system as a whole is forced to be resilient too with this pandemic. No one would have expected the pandemic would last for such a long time at the beginning of last year. By now, even with vaccines on hand, it seems that this novel coronavirus will never leave us. In most public health emergencies, we plan for post-event recovery. But for COVID, I believe that we should refrain from delaying plans until after the pandemic has settled. Rather, we should be prepared that COVID is here to stay, and health systems should make necessary adaptations. Telemedicine is an example we should further explore. Older adults are particularly vulnerable in this pandemic. The pictures here show how our geriatrics team conducted teleconsultations to maintain social distancing and at the same time sustaining quality healthcare provision for our elderly patients. Another example I would like to share as an ID and HIV physician is the rollout of HIV self-testing in a pilot study by the Department of Health during the pandemic last year. People at risk of HIV had various barriers to access to HIV testing even before the pandemic. The social distancing measures further increased their difficulties in performing HIV testing. The strategy shown here, which involves online ordering and delivery of simple self-test kits, is obviously something we should pursue to facilitate early HIV testing and diagnosis during the pandemic. I hope that the lessons that I have learned during last year would also resonate in you who practice emergency medicine. In fact, emergency medicine specialists are experts in managing emergencies and crisis situations. Your expertise and experience is essential to our planning and implementation of policies during emergency situations like infectious diseases outbreaks. I look forward to more discussion with you in the coming roundtable discussion. Thank you very much.
Thank you very much, Grace. The 5 lessons to take home are very inspirational. We'll discuss more during the roundtable discussion.